So I'll introduce Dr. Adrienne Lee, to my right here, is a hematologist and clinical associate professor in the Department of Medicine at UBC. She completed her hematology training and a 2-year research fellowship in hemostasis at the University of Calgary. She was the hemostasis medical lead for the Southern Alberta Rare Blood and Bleeding Disorders Comprehensive Care Program in Calgary until 2021, at which point she relocated to Victoria. She currently works in Victoria practicing general hematology and joined the Adult Bleeding Disorder Program in BC in 2022. Her research interests include prophylaxis, aging complications, and bone health in hemophilia adults. And she is currently Vice President of the AHCDC.
Hi, and I'm going to introduce Roy, who's going to be speaking with me about acquired hemophilia A. So he is an adult hematologist and the clinic director of the Ottawa Regional Adult Bleeding Disorders Program at Ottawa Hospital, and he's an assistant professor of medicine at the University of Ottawa. He has academic interests on medical education, research in bleeding disorders as well. So thanks, Roy, for doing this with me. And we're also very lucky to have Donna CAWKER with us, who is a patient with acquired hemophilia A, and is going to talk about her patient journey after we go through some didactic lecture material on acquired hemophilia. Do you have anything you want to say? You can speak in here. Okay, great.
All right, good morning, everyone. So we wanted to shine the light a little bit more on acquired hemophilia A, which is probably what makes our heart rate go fast as adult hematologists sometimes. I think anybody who's presenting with a bleeding disorder and bleeding makes her heart rate goes fast, but acquired hemophilia specifically, and hopefully we'll show you why. These are our disclosure for myself and Dr. Lee. So we'll go over the diagnosis. I'll take care of the diagnosis, which is the easy part for me because that hasn't changed in ever. Dr. Lee will take care of the treatment, which has changed a little bit more, and then we'll of course have the patient experience shared with us today. So this is my first patient that I wanted to describe or present. This was at during my fellowship training, and an elderly woman who was admitted to another hospital far away from us. She was there for about a month. She was admitted because of nosebleeds. Not many people get admitted for nosebleeds. And then throughout that admission, she started developing other bleeding events. So hematuria, flank pain with bleeding around her kidneys, and then with ongoing investigations and treatment, she had multiple peripheral lines put in, so PICC lines, subclavian lines, and developed further complications with kidney failure, leading to needing a dialysis line. So during that period of time where she was in the hospital for a month, she had one test done every day, which was the INR. And so I'm looking at some of the hematologists in the room, and I think their brain is exploding. The INR was normal every day. Nothing else was done except the INR that was normal every day. So finally, an internist was consulted at the time at that hospital, looked at the patient, and thought of doing a PTT, which was prolonged at 60 seconds after a month of being there, which led to further investigations and a call to our center for further testing. And of course, when we got the story, the PTT was elevated. We brought the patient down to Ottawa because of the concern of acquired hemophilia A. So this is where the ball started rolling. Unfortunately, this patient did not make it. She came to us essentially with lines that were oozing blood from everywhere. She was black and blue, which is the title of the talk, and developed a lot of complications in relation to bleeding, but also infections from the treatment that were given for acquired hemophilia A. I can talk about your patient, yes. I'm talking about Dr. Lee's patients on her behalf, but this is an 83-year-old man who was also at a peripheral hospital and requiring transfusions and blood transfusions for iron deficiency anemia. So 14 units of packed red blood cells, as you can see, 4 doses of IV iron that were given. No noticeable bleeding, but this tarry stools, black tarry stools, and a tumor that was found in the ascending colon, consistent with a colorectal carcinoma. So before surgery, the patient went in with a hemoglobin of 75, an INR of 1.0, again, normal INR, but here we have a PTT that was tested and prolonged at 63 seconds with mixing studies showing a presence of an inhibitor or an antibody to factor VIII with factor VIII at 1% and inhibitor titer of 36. So the patient was treated with amisulizumab, which Dr. Lee will talk more about in the context of acquired hemophilia A, and eradication of the inhibitor with prednisone and rituximab. No bypassing agents or hospital admissions for this patient who had improvement with the current treatment. So we do want to acknowledge the steering committee that has created these slides with support of Takeda for acquired hemophilia A and increasing recognition diagnosis of acquired hemophilia A in Canada. We've adapted some of these slides for today, but I'm going to focus on the diagnosis. We know it's a rare condition, so 1 to 1.5 patients per million. For bleeding disorder centers for hemophilia treatment center may not be as rare, but because we see all these patients come to us when they are diagnosed, there's a peak as we age. It's a condition of the elderly. We're all going to age, so there's nothing wrong with aging, but this is a condition that we see primarily in elderly patients. There is a bit of a peak in the postpartum phase, but primarily with older people. So when we say black and blue, we mean black and blue. So this is an images courtesy of Dr. Manshu Poon, who's in the audience today. This is a patient with extensive superficial hematoma or bruising. This is a classic presentation and pattern. These patients should not be sent home from the emergency room with a diagnosis of senile purpura or just bruise of the elderly. This is not senile purpura. This is acquired hemophilia A until proven otherwise. So of course the diagnosis require bleeding history. It's acquired, so there's not going to be a lifelong history of bleeding or family history of bleeding perhaps, but the clue here is the isolated prolonged PTT. Compared to congenital hemophilia or inherited hemophilia A, the pattern of bleeding is different. And we think this may be in relation to the kinetics of the antibodies or inhibitors that are in acquired hemophilia A and how they act. But we see primarily subcutaneous bleeding, bruising, superficial hematomas or muscle hematomas, as opposed to joint bleeding. Joint bleeding can happen, but they're not as frequent as what we would see in congenital hemophilia. And there isn't a good correlation between what the factor VIII that we're measuring and what the bleeding manifestations are. And that again has to do probably with how much inhibitions and how much how much residual factor VIII we're able to detect. The stepwise, steps to get to the diagnosis, again, fairly simple. If you do a PTT and you think of acquired hemophilia A, you should get to that diagnosis and get a factor VIII level, which will be reduced with the presence of a factor VIII inhibitor. The challenge is getting to that diagnosis. So the challenge is people recognizing that there is something not normal, something that needs investigations, and something that is urgent that requires more attention. So in order for patients to get to us, for us to work them up and start treatment, someone has to think about it and do that initial step. So once you have a patient who's diagnosed, not everybody may be bleeding, but oftentimes it is in the context of bleeding. So we have to treat the bleeding and identify if there's potentially an underlying condition. So for example, in Dr. Lee's patient, it was a colorectal cancer that presumably may be driving that immune process where there's an antibody against factor VIII. In my patient's case, we never identify a specific cause for why she developed acquired hemophilia A. But treatment of bleeding hasn't changed much. We have some options available. There are options that do not require factor VIII, and very rare instances where we would use factor VIII, human factor VIII. We have tried it in people with very low titer inhibitors, where we were able to manage because it was fairly easily accessible at a peripheral hospital. But generally, we use bypassing agents, so activated prothrombin complex concentrates or recombinant factor VIIa to bypass the function of factor VIII and control that bleeding event. Recombinant porcine factor VIII may be available at some centers or perhaps available through CBS if you need it. The advantage of Obizur or recombinant porcine factor VIII is that you can measure factor VIII, you can monitor and track factor VIII as you're treating the bleed. And in the context of people presenting or maybe at higher risk of thrombosis, or you're concerned that you may be driving thrombotic events with APCC and recombinant factor VIIa, you may favor recombinant porcine factor VIII. We had one specific patient, so I think Dr. Tinmouth, who's in the audience, is a co-director in Ottawa. I was also in fellowship, and I was away, I think, at a conference, and he had a call of a patient of us who relapsed for acquired hemophilia A at the same time as presenting with a STEMI or a heart attack. I do remember him texting me, and I said, I'm on vacation, good luck. But we used, or he used porcine factor VIII in that context, again, because there was an active thrombotic event or clot happening in that context. So in terms of efficacy, all of them are highly efficacious in terms of controlling bleeding, which is a good advantage for all three products. And you may be familiar with one or over the other, or they may be available, one may be available at a center versus another, and so you have to kind of work with that center and whatever they have until the patient gets to you. Risk of thrombosis or thromboembolic events for both APCC and recombinant factor VIIa is probably about similar from observational studies, and generally about anywhere between 2 to 4%, so which is not far from the general population. So I wouldn't hesitate to use these products in controlling bleeding, and especially in someone who's bleeding. But the disadvantage of the bypassing agents is that you cannot monitor. We all like monitoring labs when we're treating bleeding, but you have to go with the clinical manifestations and the clinical bleeding. The recombinant porcine factor VIII, again, high efficacy. It's based on a very small number in a 30-patient trial. But the advantage, as I said, is you can monitor factor VIII. There is a possibility where people can have cross-reacting antibodies to the porcine factor VIII. So we do test porcine factor VIII antibodies, before starting someone on Obizur. It doesn't necessarily prevent me from starting it, but we tend to measure factor VIII more frequently to see if there's high clearance, in which case you either bump up the dose or you might have to switch them to something else if you find that there's an interfering antibody. Cost is generally high for everybody, for all products, and essentially you're draining the blood bank. So you call the blood bank and you let them know, we have someone who's bleeding with acquired hemophilia A, be prepared, that blood bank's gonna get drained from that product. So from a prophylaxis perspective, so sending patients home on these products, rarely done, but it is quite costly. So begs the question about other alternative ways to prevent bleeding in these patients, especially as you wait to eradicate that inhibitor where they're still potentially at high risk of coming back with bleeding events. And so Dr. Lee will talk about some of these. I think, is it? I'm taking over Dr. Lee's part. So amicizumab is one way that you can use prophylaxis, and has shown has been shown to be effective in acquired hemophilia A. So not to treat bleeding, but to prevent bleeding. So similar to congenital hemophilia A, and the goal is to provide that function of factor VIII, which may not be as good or as high as your normal factor VIII, but again, as a bridge in the meantime, as you're getting them to normalize their factor VIII with immunosuppressant agents. It is off-label use, so it is not currently Health Canada approved or indicated in the context of acquired hemophilia A, but many of us have been successful in getting access to amisulizumab, and there have been trials primarily from the German groups, European groups on amisulizumab, more trials internationally coming out of the U.S., but with international groups about amisulizumab use and looking at it either upfront and leaving immunosuppressing agents for later, or doing both together and seeing what sort of outcomes do we get with that use. Sorry. All right, so I'll pass the baton to Dr. Lee.
Thank you. Okay, so I'm going to talk about eradicating the inhibitor. And this is sort of the second step in managing acquired hemophilia A. So this slide is basically just to emphasize the fact that while that inhibitor is still present, the patient remains at high risk of bleeding. So not until factor VIII levels, as you can see, are above 50% with inhibitor eradicated, patients can be readmitted with bleeding events. And that's where the role of emicizumab to protect them in terms of prophylaxis and prevention of bleeding until we can clear the inhibitor comes to play. So this is our current sort of available, or what we have used for eradicating inhibitors, various forms of immunosuppression. There are considerations for all different types of immunosuppressants, and the main complications we worry about are infections, but also the effects of prolonged high-dose corticosteroid use. So up front, you can use prednisone or corticosteroid alone. This seems to be less toxic than using it in combination with another immunosuppressive therapy like cyclophosphamide, which has typically been our go-to first-line therapies or second-line therapy if you're starting off with prednisone alone. There seem to be more adverse events when you combine corticosteroids with cyclophosphamide, but in registry trials, they have demonstrated that the combo of prednisone and cyclophosphamide upfront seems to have a faster response in terms of achieving that complete remission or eradicating the inhibitor. Other immunosuppressive therapies that have also been used and seem to be quite successful include rituximab, which is a monoclonal antibody, and then other less used immunosuppressive therapies like cyclosporin and MMF have also been tried, especially for their steroid-sparing effect. So one of the things that has come out of the registry studies, like the H2 registry study, is that patients can maybe be stratified into their risk and prognosis in terms of their ability to clear the inhibitor. And it seemed that patients with very low factor VIII levels at diagnosis, so less than 1%, with a very high inhibitor titer, have more trouble clearing their inhibitor with steroids alone. And so the recommendation out of the German working group was to include steroids plus cyclophosphamide or rituximab up front in order to get rid of the inhibitor faster in order to decrease that bleeding risk. Those who have maybe higher factor VIII levels or a lower titer inhibitor may do well with steroids alone, and the benefit for that is fewer complications rather than the combination therapy. And I just wanted to highlight one of the reasons why we want to look into this more, or why we should think about it, is that we have to weigh the complications that come with immunosuppressive therapy. This was a retrospective study done out of St. Mike's in Toronto, where they looked at a cohort of patients who were diagnosed with acquired hemophilia A and treated up front with corticosteroids or steroids plus cyclophosphamide. The majority of them did seem to receive both, and a lot of the complications are noted here. Neuropsychiatric complications in 37%, infection also in about 30% of patients, and some requiring readmission to hospital, and prolongs the length of their stay, which is costly. So I'm going to present a few slides on a study that was done by Dr. Cusano, who unfortunately couldn't be here today. She did a national multi-center retrospective review across 8 sites across Canada. And the goal of her study was to compare the clinical efficacy, safety, and the economic burden of first-line rituximab-based therapy. So the thought is that instead of cyclophosphamide, in addition to prednisone, which can be quite toxic, increasing the risk of infection, that maybe using rituximab up front may improve outcomes in terms of infection and adverse events. So in her study, they identified 126 adult patients with acquired hemophilia A, and followed them up for at least 6 months. And the treatments that were used include prednisone monotherapy, prednisone plus rituximab, prednisone plus cyclophosphamide, and then all 3 combined. And what they found was the remission rates were seemed to be highest in the triple therapy. But with rituximab and prednisone, the relapse rates seemed to be lower. I'll try and advance this. Adverse events, including infections, were lowest in the steroid monotherapy group, as well as the steroid plus rituximab, less than when combined with cyclophosphamide. And they also looked at the costs. So the average cost per patient in the rituximab group was $25,000 less than in the cyclophosphamide group. And this may be related to adverse events or complications. It's difficult to know if those patients also had higher titer inhibitors or were having more bleeding events, as the majority of the costs that you see here is driven by the cost of the bypassing agent that was used. So I think the point of this is highlighting some of the differences of how acquired hemophilia A is being managed now, especially with the advent of therapies like emicizumab. You can sort of see the contrast between Roy's first case versus my most recent case, who didn't even get admitted to hospital, was started on emicizumab, received rituximab, and is already starting to clear his inhibitor, and hasn't had any infectious complications. So it used to be that we focused on lots of bypassing agent up front. There's a lot of morbidity associated with immunosuppressive therapies that used to be used. And now with the advent of emicizumab, we can even look at maybe delaying immunosuppression or starting with monotherapy alone to avoid complications, adding in the rituximab for the higher titer or higher risk patients where it's more difficult to clear. So that's the background on acquired hemophilia A, and I just want to, again, introduce Donna CAWKER, who is a patient, and will talk to us about her experience with developing acquired hemophilia.
Good morning and welcome to Winnipeg. Acquired hemophilia A, it sounds like a life-changing diagnosis, but in many ways, my life has it returned to its former rhythm. In mid-November 1924, after experiencing growing discomfort and pain in my left groin area and very low hemoglobin, I was transferred by ambulance from emergency at the Victoria General to the Health Sciences Centre to be admitted on November the 19th, 1924. where hematology staff became involved and treatment began, along with the diagnosis of acquired hemophilia. And the site of the pain was located in my left groin area and the left psoas muscle, sorry. My first week in hospital remains a bit of a blur of a series of blood tests, various medications, injections, constant monitoring, and visiting by all those who were part of my journey back to health. The hemophilia team, the fifth floor ward nurses and staff, the night nurses who tended to my drip machine when it malfunctioned constantly to the tune of fill her up, fill her up, fill her up, and my own family members who visited me daily. My second week, as healing began, my appetite returned, and I hadn't been able to eat up until then, and dietetic staff added solids, and larger servings of protein foods to my tray, more than I could eat. Visitors from physio and occupational therapy began to prepare me for discharge, which included walking the hallway back and forth, and managing 4 steps. At the stage, the psoas muscle in my left groin was still very tense, and I was unable to lift my left leg very far off the floor. Sorry. I've lost my place. I'll go back. Notes for the search. Doesn't matter. My hemophilia team had me prepared by the physio team and the occupational team prepared me so that I could do the 4 steps up to my front door. Meanwhile, my family at home had prepared a downstairs bedroom for me so that I didn't have to manage the upstairs. And they also got a walker and prepared the bath so that I was able to be in the bath and use it. And that continued for about a month. Meanwhile, my post-discharge treatments continued weekly, and I came back for injections to the blood clinic. And by the time we'd had 4 injections, I was able to, my son was trained to do an injection of the hemoblab at home. And so he was trained and then was able to give me injections. And through, let me see, I think my discharge was December 3rd. I continued with loading doses through December. And then in January, my son continued with 3 more doses. And at that point, my clotting level was up high enough that I didn't need any more doses. So treatment continued with blood tests, but at this point, my clotting level has gone somewhere way above normal. So I don't really need anything but an annual or a monthly blood test, and which I had last week, and things seem to be very, very much back to normal. And meanwhile, my left leg is back to normal walking position, and I'm able to do most of the things that I was able to do before. I lost a lot of muscle while I was in bed for the 2 weeks, but with gardening and with summer and the lake, I think I'll be returning to more muscle mass and a little bit more activity. But it's been quite an experience, and I do want to thank the staff, especially Dr. Don Houston and the clinical nursing staff that looked after me from hematology. And it's been quite a trip, but two of my family are here today, and they've sort of kept me going, and that's been part of the healing. Thank you very much for listening.
Thanks so much, Donna, for sharing your experience. And I think that really highlights the part that we as clinicians sometimes forget about, is this return to function, and how this diagnosis can really change your life initially, right? So thank you for that. I think we need to close our session now. Thanks everyone for coming.